esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of entire team at MQ Pharmaceuticals. We at MQ are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with tools needed to enhance the lives of those affected with the cardiac disease. I take this opportunity to extend a warm welcome to our respected moderator, Dr. M.K. Shah, sir. Sir is interventional cardiologist at Hinduja Hospital, Khar, Bridge Candy, RK Nidhi, and BACS hospitals. Sir is practicing in Ville Parle since 1993. Faculty at many national and international meetings, including Best Paper Award for presentation of balloon dilatation of coarctation of aorta at CSI 1991. He has many publications in national and international journals to his credit. He has also authored chapters in textbooks like CSI Cardiology Update 2022, Master Cases in Coronary Interventions 2021 and 2022. He is principal investigator in many clinical trials, and his main areas of interest are complex coronary, carotid, and aortic interventions. It is an honor for me to introduce our expert panelists for today. We have Dr. Ankit Dedia, sir, cardiologist at Holy Family Hospital, Bandra, Mumbai, and Dr. Harish Bajaj, sir, cardiologist at Lilavati Hospital, Bandra, Mumbai. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll start the program with the session on optimal selection of RASI in post-MI patients by our moderator, Dr. M.K. Shah, sir. And this will be followed by panel discussion where expert panelists, Dr. Ankit Dedia, sir, and Dr. Harish Bajaj, sir, participate. Dr. M.K. Shah, sir, will drive the discussion. So without further ado, I would like to invite Dr. M.K. Shah, sir, to deliver the session and formally start the program. Over to you.
Thank you, Rishikesh, for today's opportunity. Time and again, it's due that we reconsider what we are thinking, what we are using in our clinical practice. So uh, I'll share my presentation over here, and let me know if you are able to see the presentation. Can you see the presentation?
Yes, sir. Sir, just request to make it full screen.
It is full screen.
No, it is showing presenter mode. So you can click on those three dots. It will in the bottom.
There is some challenge there.
Yeah.
I will stop sharing and restart sharing. Maybe I have selected some wrong screen. Is it full mode now?
Yes, sir. Now we can see.
But I am seeing your video over here. I'm not seeing presentation here. Fine. Okay. I have two screens connected over here. So that's the reason. Okay, friends. As I told you, time and again, we have to rethink our strategies, and particularly when newer molecules, newer modalities of therapy come with some overwhelming response in certain segments of heart diseases, many times we do get carried away. So today's session is about how to optimally select the RAS inhibitor in post-myocardial infarction subset. It is this subset where it's a very critical juncture in a patient's cardiovascular disease continuum. It's a very sensitive subset because post myocardial infarction, next couple of days, weeks, or months are going to be extremely high risk, not only for recurrent of angina, recurrent of infarction, but also in terms of mortality, heart failure, and its consequences. So we are going to review things in terms of use of ARBs, ARNI in post-MI, and use of ACE inhibitors. And finally, we are going to summarize it by looking at what current guidelines say about these situations. Going over to ARBs. The key evidence of ARB in post-myocardial infarction, there were two significant trials done in 2002, 2003. One was Optimal and second was one was Valiant. In optimal, losartan 50 milligram once daily was compared with captopril, ARB versus angiotensin ACE inhibitor, angiotensin converting enzyme inhibitor. Captopril dose was 53 times a day and losartan was 50 milligram once a day. There was no significant difference in total mortality in favor of captopril. So numerically better with captopril, statistically no significant difference between the groups. Valiant trial, a large trial, 14,000, 15,000 patients studied, and was again found valsartan was as effective as captopril in patients who are at high risk of CV event after myocardial infarction. So these were high risk myocardial infarction patients who were studied, and obviously we know very clearly that ACE and ARB should not be combined together. Combination was tried way back in 2003 and it was found to be harmful, so that should never be combined, any ACE inhibitors or ARB in in an individual patient. The primary risk in this kind of patients is because of the worsening of renal function. This is the infographics of optimal trial. It was an optimal trial in myocardial infarction with angiotensin 2 antagonist losartan. As we have said, the p-value was not significant. Losartan versus captopril primary endpoint. And the decision was that ACE inhibitor should remain the first choice in patients after complicated acute infarction, and losartan cannot generally be recommended in this group of patients. So primary endpoint, if you see, primary endpoint here, if you see, statistically it was not significant. Numerically, it was favoring captopril in terms of endpoint rates. Secondary endpoints, again, captopril was numerically better, not statistically, and tertiary endpoint, reinfarction, were significant between both the groups. This is the infographics of Valiant trial, valsartan and acute myocardial infarction. And here again, you can see versus valsartan, captopril numerically better, p-value is not significant, so statistical significance was not there. Mortality or the composite endpoint of cardiovascular death, MI, heart failure by treatment, there were no significant difference. And hence again it was shown that ARBs cannot really replace, there was no additional benefit of ARBs. Coming to ARNI, there is a lot of noise created because there are significant benefits of ARNI on top of ARB and ACE inhibitor therapy. So this was the Paradise MI trial. Paradise MI trial was presented in ACC in 2021, where neprilysin inhibition following acute infarction. What do the results say? The design of the trial was patients were either on ramipril 5 milligram twice a day or sacubitril valsartan up to 200 milligram twice a day. Almost 3,000 patients in each group. There were no running period, prior heart failure, clinical instability, and CKD EGFR less than 30 that would fall into CKD stage 4. Those were the exclusions. The selection of patient was high-risk patients, acute MI within half a day to 7 days, ejection fraction less than 40, with or without pulmonary congestion, plus any of the risk enhancing factor like extreme of age more than 70, EGFR less than 60, diabetes, previous myocardial infarction, atrial fibrillation, EF less than 30, Phillips class 3. So these were really a high risk group of acute myocardial infarction, and it was an event driven trial. So trial will continue till at least 711 events they accumulate, and that's why this trial, whenever it gets over, it reaches statistical conclusion. Whether beneficial, non-beneficial, it's a different matter. And it took them a mean of 23 months of follow-up, almost 2 years of follow-up, to get into the clinically meaningful number of endpoints where statistical significance can be drawn. And what were the results? The result shows clearly that CV death, first heart failure hospitalization, or outpatient heart failure treatment intensification was statistically no different in ramipril versus sacubitril valsartan. You can see the curves are slightly different, but there was no statistically significant difference. Both were similar. Uh, the adjudicated primary endpoint, this each and every event was adjudicated by adjudicating committee, and you can see over here even the components of the composite outcome, primary composite outcome, individual components like cardiovascular death, no difference, heart failure hospitalization, no difference, outpatient heart failure worsening requiring intensification of treatment, no difference. So, after acute myocardial infarction, high risk patients, including patients with heart failure, are a different pathophysiology. It's a different animal which you are handling, and in this group of patients, sacubitril valsartan failed to show superiority over and above the classical, well-established, well-proven molecule such as ramipril. Then now, if you see, the difference came at a cost. Hypotension was much higher in patients with ARNI, 22% versus 28%, and incidence of cough, as expected, was lower with ramipril. But it has been said that the ramipril or ACE inhibitor induced cough, in fact, selects a group of patients who are likely to be more beneficial by that. So if the cough is not severe, disturbing, I don't consider that as a very serious kind of side effect. The rest of the adverse event like renal impairment, hyperkalemia, hepatic abnormality, they were all more or less similar between the two group of patients. So this trial told us that sacubitril valsartan did not result in a significantly lower rate of CV death, HF hospitalization, or outpatient heart failure worsening. Pre-specified observations of reduction in both investigator reports of primary composite as well as the total events, they support incremental, they do not support an incremental clinical benefit of sacubitril valsartan. The safety and tolerability of sacubitril valsartan in MI population was more or less comparable, except that the hypertension was much more common. So, after this trial, what did the medical media say about that? That's very interesting. Paradise MI Medscape showed that sacubitril valsartan can't beat ramipril in patients with acute MI. ARNI doesn't surpass ACE inhibitor after acute MI. Uh, it did not outperform ACE inhibitor. So there was a big hype before this trial because in HFrEF patients, sacubitril valsartan was superior to ACE inhibitor and ARB. But here, the expectations were high that similar kind of 20-30% statistically significant reduction in heart failure hospitalization, heart failure events, even mortality would come out. And what finding we got was totally different. The old was really gold and new did not have any significant benefit. So that is something which we need to learn from the trials. ACE inhibitor post MI trials, let's see. We had SAVE trial, AIR trial, and TRACE trial. Wall motion score was assessed, and these were high risk, selective high risk long term, and there were broad short term trials like consensus GC3 as well as ISIS-4. The SAVE trial done way back in 1992, more than 3 decades back. It was on survival and ventricular enlargement study. It was a double-blind, placebo-controlled, multi-center trial. MI with LVF less than 40. Between 3 to 16 days post-MI, they were randomized. And the MUGA study was done at baseline and at the end of 3 years. Captopril 3 times a day, 50 versus placebo, and these were the follow-ups. The results were captopril group showed 19% reduction in mortality, 25% reduction in recurrent MI. That is the strength of benefit of ACE inhibitors, which was clearly shown in this trial. The cavity dilatation was reduced. That means ventricular remodeling came down. Reverse remodeling was this is a surrogate endpoint for ventricular function, which is associated with not only clinical heart failure events but all cause and cardiovascular mortality. And this benefit occurred equally in patients who received LACEs plus beta blocker or who did not. So, meaning thereby that even patients who were optimally managed with thrombolysis as well as beta blocker, on top of those very effective life-saving therapies, on top of those therapies, the benefits were shown. So that is something which is, really significant. The TRACE trial, Tandolapril, another ACE inhibitor and cardiac evaluation study. It was again a randomized double-blind placebo-controlled trial, AMI with wall motion index less than 1.2, randomized between 3 to 7 days early after myocardial infarction, practically in hospital, and again follow up for 2 to 4 years. The results was 25% reduction in mortality, 50% reduction in recurrent infarction, and 20% reduction in sudden cardiac death. A huge benefit of ACE inhibitor versus placebo. What did the other evidence-based trial showed? ISIS 4 trial, 58,000 patients, huge trial. GC3, again 19,000 patients. CCS1, 15,000 patients. What were the key findings? Captopril was effective in reducing 5-week mortality. Early benefits were there. The survival advantage appeared to be maintained in the long term. So early benefit, very early, meaning thereby if at all you want to start, you start earlier the better, because you can catch those people who are going to fall off the net within first few weeks. GC trial studied lisinopril, started within 24 hours after MI. It was effective in reducing mortality as well as reduction in ventricular function. CCS1 trial, anterior infarction, captopril treated group was found to have a lower mortality, 8.6 versus 10.1, almost 20% mortality reduction. All the findings were statistically significant. AIR study, it's an acute infarction ramipril efficacy study. Again, randomized double-blind placebo-controlled trial in acute MI, started within 3 to 10 days. Ramipril maximum dose was 5.5 milligram twice a day, as tolerated. Within 15 months, it showed 27% reduction in total mortality, 19% reduction in the rate of myocardial infarction as well as stroke. Very significant benefit. AIR extension study was done. 603 patients who participated in AIR, they were followed up further after the conclusion of trial, and it showed that over the years the benefit continued and they continued to expand. After the trial was over, and with the positive trial, now everybody must have received ramipril, because those who were on placebo, now after the trial is over and the data is unblinded, almost every patient, their clinicians must have put them on ramipril. And despite everybody getting ramipril, those who received ramipril versus placebo, the graph continued to separate out. The benefit continued, and relative risk reduction now was 36%. That gives rise to a huge benefit, that you treat 9 patients with ramipril for a year, and that will reduction in one additional survivor. One death will be prevented over 5 years. So that's a huge kind of quantitative benefit in terms of mortality reduction. Uh, uh, this was the trial of ramipril, long-term survival benefit in acute MI patient complicated by heart failure. IR survival AIR study 2021, to assess the long-term 29.6 year after randomization magnitude of impact on length of survival observed after treatment with ramipril. So patients who were initially randomized to ramipril, what is the benefit? So almost 30 years of follow-up. This is again a huge extension, 0 to 29.6 years after this. The primary outcome was life expectancy and all-cause mortality. And here it was found that median survival was much higher, 8.3 versus 9.6 in ramipril group. So median survival was increased. That showed that on an average, people who were on ramipril, their life got extended by 14.5 months. So almost 1.25 year increment in patients' life expectancy. That's a huge benefit. Of course, the benefit is seen early, and by the time if somebody had an infarction at the age of 60, by the age of 90, obviously you expect the demise to occur because of variety of reasons. But in between, large number of lives were saved, and average survival increased by 14.5 months. And it improved across all the comorbidity groups, whether patient had diabetes or CKD or COPD or asthma. No matter what, life expectancy was better, meaning thereby all the benefits seen were because of ACE inhibitor secondary to ramipril. And life expectancy difference, uh, again you can see whether you had diabetes or previous MI or hospital history of heart failure, hypertension, angina, age less than 65 or more than 65, across all subgroup, across all commodities, life expectancy was increased. So it was concluded that substantial survival gain with ramipril treatment for 14 years beyond the blinded treatment allocation showed this benefit. And believe me, these patients, majority of them, even on placebo, must have been shifted to ramipril, and despite that, the initial difference continued to benefit them. And overall, for every day patient received ramipril on an average, his life was extended by further 1 day, and relative risk of survival for patients with diabetes was increased by 54%. So in diabetic patients, the relative difference was bigger. And the benefits were seen in diabetes, previous MI, previous heart failure, hypertension, angina, each of them they benefit. 1 year treatment of ramipril when started early post MI in patients with heart failure results in survival benefit which is sustained over 3 decades. And the additional life extension is almost 1.25 years, 14.5 months to be more precise. So that is something which is which is a very humbling benefit, and we should never ever let any patient uh, uh, get denied this benefit just because we are not fully convinced about this. This is the what do the current guidelines tell us? Current guidelines are very clear about these things. Post MI, this is the state of art review post market infarction published in 2018. Index MI, immediate priority is reperfusion for ST elevation, early revascularization for cardiogenic shock, early initiation of ACE inhibitor within first 24 hours. So first day itself, unless the patient has a severe renal impairment or something like that, or the patient is in cardiogenic shock and blood pressures are 70s and 80s, if anybody who has a blood pressure of 90 and above, you are supposed to start ACE inhibitor. Initially, maybe a small dose. By 24 hours, up to 24 hours, avoid beta blockers. This is something contrary to what we used to believe 20 years back, but the recent data shows that beta blocker can wait for 24 hours. Early introduction of aldosterone antagonists, spironolactone, epinephrine, or finerenone should be given within 7 days. Reevaluate eligibility for beta blocker therapy throughout hospitalization. If they are not eligible, you might take them off. Those who are eligible should be given. After discharge, it is critical to titrate dosages of medication, including ACE inhibitors, beta blockers, and even MRA. If you have given in suboptimal dosages, it is time that you optimize those dosages, just like in patients with heart failure. And just like in patients with heart failure, first few weeks or months, uh, say up to 3 months, these patients are at extreme risk for recurrent events, and hence it is very important that you maintain this timeline to implement the guideline directed medical therapy. Early initiation is extremely important. The JACC, Journal of American College of Cardiology, acknowledges the AIR study, the first ramipril study of 1993, and it shows the very clearly that ACE should be administered within first 24 hours for heart failure patients with ES less than 40%. Heart failure patients with EF less than 40% and significant survival benefit was conferred by treating them early with ACE inhibitor. The key trials were SAVE, AIR, and TRACE trials, which are being conferred upon. This is 2018 publication. So even in 18, they say that post-infarct patients, ACE inhibitor is the way to go. The 2020 ESC guidelines for management of ACS in patients presenting without persistent ST segment elevation. Those who don't have ST elevation, again, ACE inhibitor or ARBs as per this is class 1 level of evidence A. Class 1A indication is a very strong indication. So is beta blocker, so are MRA. So acute MI, whether ST elevation or non-ST elevation, all three molecules must be given as early as possible. And the recommendation of 2025 ACCHA guidelines released just a couple of months back in February 2025. These are the recommendation, class 1A recommendation for high-risk patients with acute coronary syndrome, LVEF less than 40%, hypertension, diabetes, or elevation MI with anterior infarction. Anterior infarction is always worse than other infarction. And oral angiotensin converting enzyme inhibitor or an ARB is indicated to reduce all-cause death and major adverse cardiac events. So this is something which needs to be kept in mind. These are strong recommendation right up to the latest guidelines 2025 from major organizations. So friends, I hope I have made things reasonably clear and convinced you about the data about ACE inhibitors in post-acute myocardial infarction. Now let's go to the panel discussion. I have two very distinguished faculty with us, Dr. Ankit Dedia and Dr. Harish Bajaj. Let's hear their perspective on various aspects of this particular issue. So, Dr. Ankit, in the post-MI patients, post-revascularization, at what blood pressure do you initiate ACE inhibitor therapy? Let's take one by one. What level of blood pressure you initiate ACE inhibitor therapy? How do you titrate? How do you start? How do you titrate up? And your views on that.
So, thank you, sir, for a wonderful presentation with so many data, so much of data. As you write of these aspects where you see that ARNI cannot be given, or where the heart failure is not, your ejection fraction is preserved, but you want to save the LV for remodeling. So yes, I generally start with cardase at a lower dose, 1.25, and up titrate it as per the potassium and the creatinine. But if the patient's blood pressure is good enough, maybe if it's above 110 or so, I'll start it at 1.25 or 2.5 and check the blood pressure regularly and up titrate the dose to the maximum tolerated dose. If the patient's BP sometimes becomes 90/60 or 90/50, but patient is asymptomatic, uh, I would not de-escalate the dose. I would continue the dose because benefits of cardase would be very significantly higher as compared to the stopping the drug. So, depending if the patient is not having any clinical symptoms of hypotension or postural symptoms of giddiness or anything, then I would continue. I would accept a BP of 90/60. I would accept the BP of 90/60. And yes, gradual up titration of the dose should be done. 1.25 onwards. 2.5 is the most tolerable dose according to me, but yes, many of my patients are on 5 milligrams also for cardase.
Yes, I agree with Ankit. Start with very low dose, 1.25 milligram twice a day. So far as that blood pressure remains 90 and above, particularly I ask my staff to check it in standing posture. And if the standing blood pressure remains above 90 and patient does not have symptoms of postural hypotension, we go ahead and titrate up. And up titration happens fairly rapidly, 1.25 first day, and third day or fourth day we go up to 2.5 twice a day. And on follow-up first visit few days after discharge, if the pressure is 90 and above, particularly standing posture, no postural hypertension, straightway go ahead and put it 5 milligram twice a day. Even 90 milligram you can step up, provided you checked it in a standing posture and patient does not have symptoms. because many times very small frame patients, when we see even 80 and 85, the systolic blood pressure they tolerate very well. So 90 is fairly good blood pressure to titrate up. I fully agree with you. Any comment, Dr. Harish?
I mean, I agree with the both of you. Very nice presentation. So when Dr. M.K. Shah is speaking, everyone, is very alert, robust voice. I mean, we do agree. Many times what happens, patient who get an inferior wall MI, and not the cardiologists are present 24 hours in ICCU, and many times the intensive RMOs are there. So you may not jump so much on ACE inhibitors or even any of the antihypertensive inferior wall MI, even beta blockers, because you are worried the lower blood pressure, they can go again into hypertension or not. Entry wall MI, definitely you preferred ACE inhibitor, whatever dose you can start. And you see, unless patient has got a very low EF and going to the failure or the low blood pressure, but surely the mortality benefit is much more higher, almost 25 to 35%. And whatever is the dosage, earlier you start is better. There was some time, even if you start within first hour, also it is very helpful. Except over the period, I think the surgeons, bypass surgeons, they wanted to stop ACE inhibitor before surgery. Otherwise, I think I agree with I mean, most of the saints. Thank you.
And sicker the patient, more is the benefit. More the comorbidities, more the adverse features patient is carrying, benefit is more. Let's go to the next question. This is for Dr. Harish. Will you switch the patient to an ACE inhibitor if the patient at the time of MI was receiving ARB? Say patient had hypertension, patient had heart failure, and somebody had put him on ARB. He has a myocardial infarction. He has come to you now. What would you do? Would you switch over to ACE inhibitor? Would you continue with ARB? And what are your thought process when you
I think
face this kind of
overall for most of the MD physician and the cardiologist, ACE inhibitor ARB is more of a group effect. It's a class effect. So whatever patient is taking the medicine and is tolerating, usually you may not change unless for the blood pressure you want to change the dosages or stop for momentarily. But changing from ARB to ACE inhibitor is not common practice. I think even the trials have shown the mortality benefit of percentage wise. ACE inhibitor ARB is not much different. Like you see captopril, losartan. It is not proven that really losartan is better than, but maybe the similar effect if you take a meta-analysis. So overall, we don't shift. Only thing that ARB may have a lesser cough. That's a one side effect, maybe 5-10%. Otherwise, almost both are equally good. So we don't switch normally. Thank you.
Correct. Normally we don't switch, but in very high risk patients, I would go for even that small numerical benefit which ACE inhibitor might have. I may not do it on the first day because on the first day it's unnecessary to change over, but couple of days down the line, very high risk patients, I would think of changing to a very strong, robust, evidence based benefit which has been shown by ACE. ACE inhibitors. So that's what sometimes, but this is a personal choice. We do not have a very robust data of superiority of ACE inhibitor over the ARB. So I do agree. And it has been said that the cough is mediated by bradykinin. That's a pathway which ARB does not block. And that bradykinin in itself has a vascular benefits, vasodilator benefits, etc. And that could be identifying a group of patients where the benefits are likely to be more. That's just an observation, not a strong this thing. Coming back to Dr. Ankit, what do you feel? How early do you think an ARNI can be initiated in a patient post myocardial infarction? Or rather, I would modify the question: in which ARNI and when after myocardial infarction? Within couple of days, weeks, months, heart failure, no heart failure, reduced ejection fraction, no reduced ejection fraction. Give us your views.
So, thank you, sir. Uh, See, Arni has a very specific indication where reduced ejection fraction heart failure patients post MI. Suppose a patient has got an MI and EF is gone below 40, then Arni has a very big role to play to avoid further worsening of the LV dysfunction. Also, to regain the LV back, so Arni has to be initiated as early as possible if the patient is dry, is not wet, if the potassium creates are okay post PCI or post angiography or post stenting, if the creatinine and potassium are okay, then as early as shifting from the patient from the ICU to the ward, I would start straight away. But in a post MI patients whose EF is K, whose LV is not capacity is 50, 55, then in such a patient, I would need a ACE inhibitor like a Cardase. But at the same time, looking at the potassium creat, just shifting it the patient outside the ICU.
It is worth noting
Initially,
what were the inclusion criteria of Paradise MI trial. Paradise MI trial, practically everybody had an ejection fraction of less than 40%. And here it did not show
okay.
any superiority over ACE inhibitor. So what I would say, post MI low ejection fraction is a different animal than a regular. The classical ARNI
Hmm.
trial in heart failure with reduced ejection fraction, they were stable patients. They did not have an acute event couple of days, weeks, or months back. They did not have an acute myocardial infarction. There it did show a significant 20-25% reduction in major adverse cardiac events as well as 20% reduction in mortality, a huge benefit. That benefit was not seen if
Hmm.
the patients were equally or more sick in a post myocardial infarction. And that is the reason in this group of patients, if I had to consider switchover, I would consider it after a couple of weeks or months. Immediately they will go on ACE inhibitor because these are exactly the class of patients which are included. See the inclusion EF less than 40 and pulmonary congestion. And on top of that, they had to have some high risk factors. Even in those high risk factors, probably ARNI was not as well tolerated as ACE inhibitors, but it did not show any significant benefit. So something is happening on ARNI arm over this group of patients, and that's why probably I would wait for a couple of weeks or months and see if the patient is doing well. Ejection fraction is more than 40. I would not switch over. If it's less than 40, patient has a symptomatic heart failure, I would definitely go ahead and give the benefit of ARNI because now that patient will fit into the inclusion criteria of Paradise trial. So, what do you think, Harish?
Regarding the army, you're saying, right?
Yeah,
I
ARNI,
don't, I don't see any time that
post MI ARNI.
correct. I don't see any hospital, any cardiologist that patient got an MI, even though interval MI, and ARNI is given in first 24 hours or 48 hours.
Right.
Sometime initially when the ARNI hype was there, few patients received an ARNI within 48 hours for acute MI, and some of the patient went into severe hypertension or renal failure or hyperkalemia. So I think ARNI is not, even though they are saying that you start in before discharge, but it is not that common, even though there may be suggestions. So I feel still this practice of giving ACE inhibitor initially, whatever ARB ACE inhibitor, and then you follow up. And once the patient stabilizes, and then you start RNA. I think that is quite common to
Agreed.
practice.
Agreed.
But not in first 48 hours or first within a week. I'm not sure.
But in a purely heart failure patient who does not have acute MI, first 24-48 hours are good enough if the patient is not on ionotropes or patient is not hypotensive.
Yeah, so, but what is happening? Suppose a patient comes after 6 weeks, of an MI, and he
After
still has
6 weeks
EF
of MI, it's no longer an acute MI.
Yeah, correct.
It's no longer an acute MI, then the whole subclass changes, whole recommendation changes, everything changes. Now the next question is to you, Harish. Post revascularization, angioplasty or bypass surgery, if you find LV systolic dysfunction, EF is less than 40, patient does not have a clinical heart failure. He is NYHA class 1, he does not have congestion, he does not have edema, he does not have craps, he does not have orthopnea, PND. Would you use RAS inhibitor either in the form of ACE inhibitor or ARNI?
Yeah.
The
See, the
question is a little vague whether we are talking about
yeah, understood.
acute MI revascularization or a
Mhm.
chronic coronary syndrome revascularization.
See, practice 15-20 years ago, almost 40% of palmoplasties were chronic patients. But
Right.
now you see almost 80 to 90% patient have ACS.
Right.
So I think the word rule stays in acute MI, same is here for an ARNI. As the 90% of patients, they come with an acute angina, with ECG fluctuating changes, tropa elevated, and you do plasty. 30 to 40% is an emergency, late evening or night plasty. So we don't touch such patients with ARNI. So rule goes same, you use ACE inhibitor or ARB for EF below 40%. And once patient stabilizes, I mean, acute becomes subacute in weeks time, then you go with an ARNI. So I think predominantly ACE inhibitor over ARNI. Yes.
Correct. Because we don't want any hypotension immediately post revascularization area. Maybe wait for a week or two. Initially start with ACE inhibitor, wait for a week or two or maybe couple of weeks. And then if he is still falling into HFrEF category, even if asymptomatic, the patients who have a low ejection fraction, heart failure begets heart failure, and they will continue to have cardiac remodeling, which is harmful. Ventricle will continue to dilate, and few years down the line, you will find that the patient is in a very bad heart failure, and then he falls into the category of patients who do not respond well to your foundational core therapy. So to me, any ejection fraction less than 40%, symptomatic or not, is a case for RAS inhibitor. Now, the question goes to all of us. In the post-MI patient, after revascularization, when do you like to start beta blocker? Patient had an acute MI and PAMI or a rescue plasty has been done, or elective plasty post thrombolysis or a late presentation has been done. When do you start beta blocker? Which beta blocker do you prefer, and what dose? How do you initiate? How do you titrate? And what are your thoughts about combination of ACE inhibitor plus beta blocker?
See, almost 30% of plasties, patient has tachycardia during angioplasty. So it is quite common that we just give injectable metoprolol during the plasty is going on itself. Because if the moment you see the heart rate is above 90, 100, you would inject more contrast, the visibility is not good. So beta blockers are so common that many times even before taking patient for like patients come into ICU and you find there is tachycardia with a high blood pressure, entry wall MI, not in failure grossly. You give beta blockers, even like injectable Harrison dose before brown wall 444. So it is not uncommon using beta lock injectable 5 milligram, 10 milligram, even 12 to 14 milligram. So you can start before plasty, during plasty, or at the earliest, unless it is contraindicated. Contraindicate same thing: severe bradycardia, heart block, hypertension, heart failure, rarely wheezing. I mean, we had a patient 2 days ago. Patient we put on bisoprolol. Patient had AF with the hypertension, even after cardron, this tachycardia. And moment he gave bisoprolol, within 12 hours he had a severe wheeze. So our MD medicine has to stop. Given bisoprolol also, they found nebivolol better than bisoprolol maybe, but still wheeze can happen with anything. So when you give an injectable metoprolol, then you stick to metoprolol. Maybe arrhythmias are lesser, but it could be a class effect, but it's a personal choice. Either metoprolol, bisoprolol, then you see the side effect. And go to the maximum dose, so the heart rate stays around 65, 70. And even if patient walks, it should stay like that. 50, 55, the books mention, but many times patient do not tolerate. So still, I think 65, keeping the heart rate around 65 and the maximum dose is quite better. Thank you.
Particularly in acute situation, you do not try out extremely low heart rate. I do agree 65 should be the target. If somebody achieves 70, then you can wait for a few days, because many times within a day or two, you don't get the peak effect of beta blocker coming. And the anxiety related little higher heart rate is going to stabilize in couple of days down the line, or once he goes home. So I do agree it should be a bit slow titration. But yes, if somebody whom you have given 25 or 50 milligram of metoprolol, and on next day also his heart rate is 80s and 90s, even at rest, when he is not doing anything, he is not anxious, probably there's a time when you can go from 25 to 50 to 50 to 100 milligram. And what's your thought about the combination of ACE inhibitor beta blocker in this situation? The patient had an MI, he has revascularization, and
normally within few hours, within few days, we don't go with combinations.
absolutely.
Once you discharge patient 3, 5, 7 days and follow up patient tolerates, then you do. Otherwise, combinations in acutely we don't use. Still, I think after a month, we have 90% patients only on combination, not as a alone drug. But initially, we don't use combinations.
Your views, Ankit? Your views, Ankit? I think Ankit seems to have some issues with his net. It's got disconnected. But yes, in an acute situation, in up titration phase, you do not know which one you are going to titrate, which up titration patient is going to tolerate. So in up titration phase, it is better to go slowly and individually. After a couple of weeks down the line, patient is on a fixed and stable dose of each molecule. That is the time when you switch over to the combination therapy. If Ankit is
Yeah.
there, the question for Ankit, do you
Yeah.
consider anti-pro-BNP as a
Yeah.
deciding marker for choosing ARNI over Ramipril? Now it is not very defined in the question whether talking about regular heart failure patient who has come to your OPD or acute worsening. We're talking about acute MI. But would anti-pro-BNP a deciding factor between ARNI and Ramipril?
No, I personally I don't feel that leading factor, but yeah, we do check NT-proBNP patient in all our acute MIs and in heart failure patients. But the treatment modality will be decided based on the patient's condition and ejection fraction and the timeline from the acute MI or if it's a chronic heart failure, again it's going to be ARNI. But in an acute MI patient, which I'm expecting the question to be, then in that situation, even though NT-proBNP is high, uh, first few weeks, I would still recommend patient to be on ACE inhibitor.
Correct. So we do expect NT-proBNP to be elevated in acute MI, particularly large MI with a reduced ejection fraction or high risk MIs. And that is not really the deciding criteria. None of the trial, there was a criteria that if NT-proBNP is this much, you give ACE inhibitor, otherwise you don't give. So yes, I do agree, NT-proBNP, we do it, and that kind of works as a baseline value against which few days, weeks, or months down the line you compare how much is the patient's improvement, whether the patient has residual LV dysfunction, heart failure or not. But that's not the deciding criteria. No matter what is your anti-pro-BNP, acute MI, we would be going for Ramipril. The focus again on Harish. Will you start ACE inhibitor in all the patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefit? So is revascularization a deciding element whether to start ACE inhibitor or not, or all acute MI patients would receive ACE inhibitors?
Usually, we start ACE inhibitor only for the patients who have, for example, either a diabetes or those who have hypertension or those who have EF going below 40%.
Correct.
Just having an ACS without diabetes, without hypertension, EF is 60%, maybe like an interval MI, we don't start ACE inhibitor. So interval MI with EF below 40% or hypertension or diabetes, then you start ACE inhibitor, but not, it is not that all patients used to start. Thank you.
Right. Any opinion, Ankit? Now, regarding the tolerability of ARNI versus Ramipril full dose. Full dose of Ramipril is 5 milligram twice a day. ARNI is 200 milligram twice a day. So what is your opinion? Which molecule is a little more tolerated or more frequently you can give it in the post-MI patients? Ramipril 5 twice a day or ARNI 200 twice a day? Maybe Ankit can take
So
that.
I think, see, post MI patients, Ramipril 5 mg BID is more more because 200 BID for ARNI, it takes much longer duration, and not many patients in India, at least my patients, not many of them tolerate 200 BID. So, but definitely 5 mg BID, it's very much tolerable. Patients are not having any major side effects or hypotensive episodes with 5 mg BID. Multiple patients are there on 5 mg BID. So this, between the two, yes, Ramipril 5 mg BID is more tolerable. If you have to compare, if you are ruling out chronic heart failure, then yes, Ramipril 5 mg BID is more tolerable as compared to ARNI 200 BID.
And I feel this is the primary reason why ARNI failed to show benefit over Ramipril in acute MI. Large
Yeah.
number of hypertension in patients who were just recently revascularized or it did something to the microvasculature which is defective in an acute coronary syndrome, or this kind of hypotension in people who are not completely revascularized. Every patient does not get a complete revascularization. There are few blocks here and there which we are obliged to leave behind. And that's the reason an ARNI 200 twice a day to develop takes at least 1 month time, sometimes few more months. While Ramipril 5 milligram twice a day to reach does not take more than a week or 10 days. First day it is 1.25 twice a day, second to seventh day, depending upon the blood pressure, it goes to 2.5 twice a day, gets discharged. Next visit when he comes, his BP is 9500 systolic. You go ahead with 5 milligram twice a day. So I think with Ramipril 5 milligram twice a day, I would be able to reach in 50, 60, 70% of my patients. While ARNI 200 milligram twice a day, you will be able to reach hardly in 10, 20, maybe 25% of patients. So larger percentage of patients will achieve full dose of Ramipril in my clinical practice. Now, I think 1 hour is about to be over. And thank you very much for a very lively discussion. I thank and congratulate both my colleagues, Harish as well as Ankit. And I would hand
There
over
are
the
few
control back to
questions in
Rishikesh.
the chat box. There are 2 or 3 questions in from the audience link, which are put in the chat box. So if you can click on the chat box icon in the bottom.
I did click, but I think chat box from the audience may be with you. We don't have any questions over
Hey,
here.
in this faculty link, we have pasted, sir.
I am linked into only one link, that is faculty link. If you can read the questions, we'll discuss it.
Okay,
I
okay, sir.
can't
I'll
see any
read.
questions here.
Okay. So first question is, sir, which RAS inhibitor is superior in high risk populations like hypertension plus type 2 diabetes? Will you prefer ARB or ACE inhibitor?
Yes, Ankit or Harish Bajaj, this is a difficult ball, and if you can handle it, better. This is not about an
Yeah.
acute patient. Yeah.
So again, the question is which RAS inhibitor is superior in high risk population, hypertensive and diabetic? So again, see, this is be the question is very broad spectrum. The ejection fraction, the MI status, nothing is mentioned, but it's just for hypertension and diabetic patients. So both there it is a non-inferior. If you see both the drugs are more. So, but both are equally good. I don't think there is anyone additional edge. But as I said, post MI patients, if the patient had or something like that, an ACE would have a slightly better edge of the abuse.
Yeah, your Ankit's voice was cracking, so I could not get everything. But yes, I do agree. In diabetic hypertensives, you can use ACE inhibitors or ARB interchangeably if it is not an acute MI. If it is an acute MI, yes, we would be using selectively ACE inhibitors. For hypertension, if the patient has a renal involvement, if the patient has proteinuria or CKD, early CKD, then probably ARBs would be shared better. Beyond that, a regular hypertensive diabetic, I think ACE inhibitor, ARBs are interchangeable. ACE inhibitor is my first choice. Only if somebody does not tolerate, intolerable cough is there, then probably I would switch to ARBs. Now I can see all those questions, Rishikesh. The second question
Yes,
is how to achieve higher dosages of ARNI. He feels that Dr. Surendra Bhardwaj's question. He feels that maximum he can achieve is 50 milligram twice a day. What strategy we can use to increase the dosages? Harish, would you like to comment?
See, normally in the army, when you start with the 50 milligram, and once you see the patient is dry, for example, his fluid intake is reduced, salt intake is reduced, you will see the BP is coming up, then you reduce the diuretics. So to reduce same Lasix or Ditor, they are not required. So moment you reduce the diuretics, the dose can increase. Sometimes you feel, you have to just see the SL inhibitors and the beta blockers, those, but everything should be there amongst the 4 pillars. And I think this is the best way. Reduce the diuretics, And as the time passes, you can go. I think 50 milligram BD is achieved required in 30 to 40% of the patient. I think another 30-40 can go to 100 BD. 200 BD, I think, is less than 20% of the patients. Thank you.
Yes, what I do in my practice to step up to 200 milligram, almost 35-40% of my heart failure patients are on 200 milligram twice a day. I encourage the patients to take off nitrates, take off diuretics. If they are on other antihypertensive drugs, I would like to take off. Diuretics are first to go away, and within a day or two, the patient will tolerate a little higher dose. If not, from 50 to 100 twice a day. Sometimes what I do is give them 50 in the morning, 100 in the evening, so that during night anyway they do not need very high pressures. They would tolerate. After a couple of days, heart failure will improve, and then they will be able to tolerate 100 milligram twice a day. Same strategy can be used when you are titrating up with a ramipril from 1.25, 2.5 and 5 when you are stepping up finding this problem. One thing is important to understand that 90 systolic pressure is not hypertension. Only seeing 90 systolic pressure in your clinic should not deter you from stepping up the therapy. Symptomatic hypotension is the only reason why you do not step up. If the patient's blood pressure is 90 and above, and he does not have any postural hypotensive symptoms, maybe you can check his blood pressure is standing position. If it is not dropping, then even at 90, be bold, go ahead and step up. If you are not very bold, maybe you can use halfway, 50 morning, 100 evening, call him back again after a week's time, 100 morning, 100 evening, call him back again after a week's time, BP is 90 and above, no postural hypotension, 100 morning, 200 evening, and then after a couple of weeks, maybe 200 morning, evening. That's the practical which I use, and I have one of the highest conversion to 200 milligram twice a day for Arni, as well as 5 milligram twice a day for ramipril.
There is last question, sir. On target trial showed a similar efficacy of ARB to ACE inhibitor, but there was increased incidence of MI. And in transcend trial, telmisartan was not superior to placebo. So what is your opinion on this?
Well, this trials practically reconfirms what we have seen in acute MI trial also. There was no significant superiority or inferiority, only numerical advantage was there with the ACE inhibitor. So I think you are never wrong whether you use ACE inhibitor or ARB in this kind of chronic situations. On target myocardial infarction signal was there, but it was a very small signal, and it has been disproven that it was related to any specific effect of olmesartan, telmisartan, etc. With olmesartan, one of the rare side effect, GI side effect of chronic sprue-like syndrome should be kept in mind. If your patient starts losing weight on olmesartan consistently, strongly, without making any efforts, stop olmesartan, and within a few weeks time he will improve. That's the only clinical point which would like to bring to your attention. Unexplained weight loss in a patient who is on olmesartan, which is a side effect specific to olmesartan, and you should immediately think of it. Either refer to a gastroenterologist, get an endoscopy done, or if the patient is not affording, just go ahead and stop olmesartan. Within a month's time, he will start regaining his weight.
Okay. Thank you, sir.
Right.
So before we conclude, I would like to express my sincere gratitude to our esteemed moderator, Dr. M.K. Shah, sir, for delivering the excellent session and driving the interesting panel discussion. I would also like to thank our expert panelists, Dr. Ankit Dedhia, sir, and Dr. Harish Bajaj, sir, for sharing their knowledge and expertise with us today. I would also like to thank our esteemed audience for their time, continued love, and support for the Cardio Colloquium program. On behalf of MCure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MCure who have contributed to this program success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you, everyone. Bye-bye.
Thank you,
Thank you,
everyone.
sir.
Thank you.
Thank you, sir. Good night.
Bye, everyone. Bye.